All right, everybody. So it is my great pleasure to introduce Christina Rossitto. Many of us have gotten to know her over time. She's been very engaged with research in our department. She went to undergrad at MIT, where she majored in biological engineering. And she's been a medical student here, working with us really since the first day of her time with us in medical school. She had a very productive year working with me and the rest of the vascular department, and also some other individuals in the department. She, during this year, won a $50,000 NSF grant to participate in an accelerated program working with Sinai Biodesign, and was extremely engaged in that and interviewed, I don't even know how many people, 50 to 100 experts in the field, who gave insight into a specific technology that she was interviewing them on. And something I just learned recently is that she's also president of the Sinai Ski and Snowboard Club. And so she's going to talk about some of the work she did with me and Dr. Mako this year.
Thank you. Okay, so today I'm going to talk about some research that we've been doing looking at diffusion-weighted imaging lesions after ICH evacuation. And this presentation is based on work that's under revision at JNIS right now with the co-authors that are listed here. Here are our disclosures. The slide is loading, sorry. Okay, the first slide has a GIF of an ICH evacuation, so I think that's why it's not. Oh, here we go. Great. So as we know, ICH is a devastating disease with a significant one-year mortality rate. A meta-analysis of randomized clinical trials on minimally invasive surgery for ICH demonstrated promising results regarding functional outcomes. And recently at the AANS, the ENRICH trial was presented, which was a multi-center randomized clinical trial comparing hematoma evacuation to medical management. And ENRICH demonstrated that patients with lobar hemorrhages between 30 and 80 milliliters benefited from minimally invasive surgical evacuation. Prior studies on DWI lesions have shown that they are linked to poor outcomes after ICH. The prevalence has been shown to be about 45.9%. And previously identified factors associated with DWI lesions after ICH include systolic blood pressure elevations, cerebral microbleeds, and leukorrheosis. And studies on cerebrovascular diseases have reported an association between DWI lesions and digital subtraction angiography, with a prevalence then as high as 70%. The prevalence and factors associated with DWI lesions in patients after surgical evacuation of ICH have not been described previously. So in this study, we looked at 170 patients who underwent ICH evacuation and also had MRIs available for review in the acute postoperative period. During our initial experience, during Mount Sinai's initial experience, there was a low threshold of performance of DSA, which was used to exclude macrovascular causes of ICH, although generally advanced age and characteristics consistent with a hypertensive bleed would exclude the performance of DSA after CTA. As Mount Sinai's institutional experience with CTA increased their confidence in identifying vascular malformations, stricter criteria was applied, and patients were considered for angiography only if they were under the age of 65 and without an etiology for the hemorrhage, such as cerebral amyloid angiopathy or hypertension, and if they had a concerning finding on CTA. So in this study, our MRIs were reviewed by 2 independent investigators. DWI lesions were identified as punctate lesions that were less than 1 centimeter, in size and over 1 centimeter outside of the hematoma border that were hyperintense on DWI and hypointense on ADC. We also looked at leukoariosis or white matter hyperintensities on T2 flare and quantified those using the Faseca scale, which ranges from 0 to 3 in the periventricular and deep regions. And we also looked at microbleeds and siderosis on GRE. In our patient population, there were no significant differences in age, gender, race, or medical history in patients who did and did not have DWI lesions. Patients with DWI lesions did present with higher NIHSS, lower GCS. They more frequently had intraventricular hemorrhage, and they had larger preoperative volumes. We found a significant difference in patients who underwent preoperative DSA and those who did not. We found the angiogram nearly doubled the rate of DWI lesion detection. So based on this finding, we split our cohort by DSA history to look more specifically at risk factors for DWI lesion detection in each group. In the patients who had undergone DSA, we found on univariate and multivariate analysis that NIHSS, age per decade, leukoariosis, and preoperative hematoma volume were predictive of the presence of DWI lesions. In patients who did not undergo DSA, we found that NIHSS, elevated systolic blood pressure at presentation, and IVH were predictive of the presence of DWI lesions. As a secondary endpoint, we wanted to understand the impact of DWI lesions on these patients' long-term functional outcomes, defined as the modified Rankin score at 6 months. And we found that DWI lesion presence was not significantly predictive in this cohort, likely due to small sample size, but DWI lesion burden, defined as the number of DWI lesions per MRI, was predictive of worse functional outcome at 6 months. So these findings are important because DSA is commonly employed to prior to ICH evacuation to rule out underlying vascular malformations and aneurysms. The ICH guidelines currently from 2022 recommend DSA after CTA as a class 1 recommendation if the CTA is suggestive of a vascular malformation, and as a class 2A recommendation if the CTA is negative. Prior studies have shown that CTA is over 90% sensitive and specific for detection of vascular malformations compared to DSA. So it's important to remember that DSA is not without risk. In conclusion, in this cohort of ICH patients who underwent minimally invasive endoscopic ICH evacuation, pre-procedural angiography was associated with the presence of DWI lesions on the post-ICH evacuation MRI. And furthermore, the burden of DWI lesions portended a worse outcome in these patients. I want to use the last couple of minutes to briefly touch on some of the other projects I worked on this year. As Dr. Kellner mentioned at the beginning, I studied biological engineering, so I'm really interested in innovative imaging in neurosurgery, and something that's unique to Sinai and from my experience was the ability to collaborate with engineers at biodesign and in industry groups to improve neurosurgical technologies. Last month, I shared my experience using surgical theater to test virtual reality for surgical education. I also worked with Dr. Betterson and Holly to review the value of heads-up display and intraoperatively, and with Dr. Kellner and Dr. Mako on other imaging techniques for ICH. So thank you so much to the department. Thank you to my mentors. This is my last week on sub-I, and I've learned so much this month, especially from the aneurysm clipping yesterday. So I'm just so grateful for all of your mentorship. Thank you.
Great work, Christina. Really fantastic. I don't know if anyone has any questions, but I think this is important. It's been a long time since I've received feedback from a journal that was so overwhelmingly positive on a paper. And there was a lot of enthusiasm about this. I think it's going to have a real clinical impact.
Thank you.
These findings you have formally made, we noticed along the way, and so did modify our practice and increased the threshold for performing DSA preoperatively. And I think one finding that's really interesting that you had is that the size of the hematoma and the severity of the NIH stroke scale, so the poor neurologic exam, correlate to increased EWI lesions. And so that hints at a mechanism that when the brain is under more stress and globally the ICP is threatened and the perfusion is threatened, then the procedure itself has increased risk. And so we have to take that into account and decide carefully who to perform it for.
I'm really glad you presented this. I have long been worried about the impact of angiography on little white spots. And rather than do a global thing, you focused on a very specific disease entity. I think you guys are courageous for showing this. And it shows the level of quality of internal quality control on what you're doing. So it's wonderful work.
Thank you.
All right, thank you, everyone. Christina and Alex and Janina, great job today. We're going to pick up next week with our last two sub-Is presenting, and we'll see you all next week.
Okay, thank you.